Okay, good afternoon, everyone, and thank you so much for joining us today. Please feel free to keep your video on so it could make it more live and real. And welcome to the next inaugural lecture for MAHSC Inaugural Lecture Series, which is celebrating the incredible honorary MAHSC clinical chairs. So today, we will have Professor Daniel Horne and Professor Martin Smith, and they will be introduced by Professor Paul Dark. So please feel free to put your question in the chat box, and please keep your question by the end of each talk, and we'll make sure to cover all of the questions you do have for each of our speakers. We're really looking forward to celebrating both of our professors today, and I will hand it over to Paul, please, now. And by the end of each talk, as I mentioned, we will cover the questions. Paul, please hand it over to you.
Thank you so much, Yasmin. Can you hear me okay? That's great. And thank you for organising this event. It's a great celebration, as you say. My name's Paul Dark. I'm the new Vice Dean in the Faculty of Biology, Medicine and Health for Health and Care Partnerships. This is my first week in post, and it gives me enormous pleasure to introduce the speakers today. And of course, the MAHSC honorary clinical chairs are really important to us as a university, and we hope important to our partner NHS Trust, and particularly for Dan and Martin at the Northern Care Alliance. As Yasmin has said, it really is about celebrating service leadership, specialty excellence, and research and education excellence in partnership. So without further ado, I'm going to invite, I think Martin is going to speak first. Martin is a colleague of mine. We trained together for many years in emergency and critical care, and I'm really pleased to welcome Martin today to celebrate his promotion and to listen to what I think, and I know, is going to be a really interesting talk. Thank you.
Thank you, Paul. I'll now see if I can manage to successfully share my screen. Just need to pop it onto slideshow. There. Hopefully that's showing the title slide.
That's great, Martin.
Great. Paul, thanks very much for that kind introduction. And yes, as you say, we do go back a long time, sharing opposite ends of the ITU ED rotation. So thank you very much. And without further ado, I've titled this talk Accidental Academic. I think I'm very fortunate to be surrounded by a lot of professional academics, and they've been very kind enough to let me hold on to their coattails over the last few years or so. I am a local lad. I was born in Stockport, and I've put a little picture there of the maternity unit because we're exactly the same age. I'm pleased to say we're both still standing, though I suspect neither of us have any particular architectural merit. I continue to grow up in Stockport, and it's thanks to L.S. Lowry there in his picture of the viaduct that I recognise my roots. I actually didn't want to be a doctor. I was keen to be a vet, and both of these two books were instrumental in my early years. However, I was allergic to horses, so I ended up going to Edinburgh instead to do medicine. And I dug out an old photo there of the anatomy lecture theatre, which was indeed the very anatomy lecture theatre that I spent so many hours in. As you can see, it really wasn't designed for comfort. And despite my best efforts, it was quite difficult to fall asleep there. I hung around in Edinburgh, did my house jobs, and then did vocational training in general practice. And that was a very enlightening experience, because this was 1980s Britain. The area I was doing my general practice was in the Midlothian sort of coalfields, which were no longer coalfields due to Margaret Thatcher's impact. And so the old picture there actually looked very little different when I was working as a GP in that area. There was a significant amount of deprivation as a result of high unemployment and huge problems with drugs and alcohol and challenging access to urgent care, which always seemed to hit the hardest, the least able to manage. And the other thing that was rising and becoming much more prominent at that time was HIV and AIDS. And in my primary care practice, it wasn't unusual for people to present with strange black spots on their skin as a first presentation of their HIV. So an interesting and novel virus, and I'll come back to novel viruses at the end. I did see the light and head away from Scotland for a short period of time and spent a year down in New Zealand. And this I point to as a sort of transition in my career, because I did and concentrated on acute care. I was lucky enough to do intensive care for the first time. I did critical care, heart care and A&E. And it was at that time where I realized my general approach to medicine could be shared, but in a more acute setting, and hence where I identified my desire to do emergency medicine. It was also the time where I recognized that some of the things I'd been taught weren't necessarily true. Edinburgh is very strong on colloid resuscitation. And when I went to New Zealand, I discovered crystalloids, and I got stuck in the battle between the two for many years. I also, it took me all the way to go to New Zealand to discover something called the Glasgow Coma Scale. I'd been brought up in Edinburgh and been told that the Edinburgh version was much better. I think time and the international view would suggest that Glasgow perhaps were right. And the other thing that I came across was that nurses were able to extend their practice incredibly effectively. And it was there that I first came across the concept of advanced practitioner training. And so my time in Christchurch was really quite eye-opening in many ways. I came back, and as I say, I felt that my interest lay in acute medicine, and I was lucky enough to spend some time working in Stoke when it was performing its role as the major trauma centre trial that was run by John Nichol out of Sheffield. And though I personally felt that I recognised the benefits delivered by consultant-delivered care, and as a result, the perhaps more profligate use of complex imaging, this wasn't necessarily recognised in the conclusion of the trial, which felt that the trauma network model wasn't one that might necessarily benefit the UK. And interesting to note where we are now, 2 NCPOD and a Royal College report to challenge that view. It was also the time I first came across a gentleman called Tony Redmond, who was really quite an inspirational character throughout my career, as you'll see. One of the things I did learn from Tony was the benefit of having significant airway skills. So my next step was to do a year's anaesthesia, and this brought me up into Manchester, coupled with some intensive care training. And it really was an inspirational time to be in Manchester for emergency medicine training. And I've listed a number of colleagues there who were inspirational consultants who were very, very important to my registrar training. I couldn't resist putting a photo there of some of my registrar colleagues who I had a fantastic 4 or 5 years training. Sadly, Paul, I didn't have a photo of you, I'm afraid, from that era. So I'm sure you'd look very different from what you do now. As I say, Manchester was chock full of people who were at the forefront of emergency medicine, and I've just captured a few of the faces and a few of the projects and innovations that they were key to sharing nationally and internationally. I was appointed to Salford Royal in 2003, and I joined 4 colleagues, and between the 5 of us, we shared out the responsibilities. And one of the responsibilities that I purported to have a special interest in was paediatrics. We were at a particular point in time where paediatric support from our local hospitals was becoming a little more distant. And as a result of that, I spent some time working alongside colleagues at the Royal College of Paediatrics in defining some of the standards that were important for emergency medicine when it looked towards paediatric delivered care. And a result of some of the reconfigurations and the development of the PANDA unit, of which our next slide covers, I was also part of a working party who wrote a paper on short-stay paediatric units. I mentioned the PANDA unit, and that is the allied unit to our emergency department here in Salford that manages both accident emergency presentations, but also acts as an observation unit for kids. In some ways, it's probably a forerunner of the SDEC model that we see now so prevalent. Very important, I think, because a lot of reconfigurations focus on the hub sites, and I think it's important to remember the gaps that any reconfiguration may convene, and think about how one provides care into the gap sites, particularly when those gap sites are again areas of significant social deprivation. And once again, Tony Redmond came into the picture. He came here as the hospital dean, and he was very helpful in allowing me to take up a position of the associate hospital dean here in Salford, with a particular interest in skills and simulation. I was able to start a process that developed training in simulation for the 3rd year medical students, and I'm pleased to say that still is prevalent and a core part of their training to date. One of the other aspects that he got me involved in is student support for failing students, perhaps a poach return gamekeeper. However, I did find this a particularly interesting area, and hopefully I carried out my duties in this area to good effect. On then with other areas of paediatrics, and for my sins, I got involved in some of the early development work in the small group teaching for APLS, one of which was filming a video which ended up on the international VLE. I was lucky enough to go to Sweden with APLS in its first edition, and bizarrely ended up involved in writing the POE manual, despite only having ever had 6 months obs and gynae training. So ALSG and the links between Salford and ALSG has always been a very strong element of our care here in emergency medicine in Salford. Other aspects as clinical director, one of the issues certainly in Salford is alcohol related admissions. I got embroiled in some of the Healthier Together work, which was fascinating, gave me some insight into some of the change management, but also I got some training in media studies, which seemed to be a study of how to avoid answering the question and saying what you were going to say anyway. And finally, perhaps that training was helpful in some of my latter work, where I ended up as clinical lead for the Major Trauma Network. And then I'm just going to pause for a second, because during that Major Trauma Network period of time, we had the catastrophic events in Paris. We had a national response to those catastrophic events, and a learning experience hosted by the Queen Elizabeth Hospital in Birmingham. And it was travelling back from that period of the conference in Birmingham, where some of the questions about how our trauma network here in Manchester might respond to a similar event to Paris became forefront in our minds. And over the next 9 months, colleagues, of which I was part of a team, developed a process of how we might manage significant number of casualties spread between the now newly configured major trauma network. And it was this piece of work that hadn't finally been completed. It had been tested but not signed off, that was present in our minds when the events of the arena happened in May of 2017. The decision on the night, and I think it was a brave decision by the EPR lead at the time, but one I think that probably was helpful to patients' outcomes, was to enact that dispersal plan. And we've seen, I guess, how that has was effective in that no patients that arrived in hospital, I'm pleased to say, were subsequently died. One of the other areas of, I suppose, helpful coincidence was the presence of tarn in the city, and when the events of the arena unfolded, we were in a position where we were able to submit all of the patients' details who attended that night, rather than the usual refined entry criteria for the TARN database. And that allows us to capture for the first time the presentations and the case mix generated by such a major incident. We were able to define the times that patients attended the emergency department, when they went to theatre, how many times they went to theatre. We were able to look at some of the urgent care data that's captured in Manchester and see the impact of the event in relation to the A&E attendances, but also compare it to the ambulance A&E attendances. It's interesting to note that the overall attendances dropped, but the ambulance attendances didn't. In other words, I think the sickest patients were still being delivered to hospital in the days and weeks after the event, but there was a tail off in people accessing hospitals themselves. We were able to look at how the elective caseload was impacted by the arena. And it's interesting to see how significant the numbers were, but relatively short before normal business as usual was resumed. And perhaps, and we commented on this at the time in the article in the BMJ, this switch over from major incident mode to business as usual was perhaps a little too quick. And maybe we've seen that play out in COVID in latter years. The data we produced was very helpful in further major incident plans. It was helpful nationally in planning blood transfusion quotas, and was also that dispersal plan became the norm for the concept of operations nationally in its response to the mass casualty scenario. The other aspect that we commented on in some of the hot debriefs was the need to perhaps consider a reframing of the triage of patients in a major incident, recognizing the dichotomy between those patients that stand up and those that lie down. And it's interesting to see how that has evolved, and perhaps is the you can see the origins of that in the 10-second triage work that's just most recently been produced. Again, I'm going to pause for a second and think about other things that are important in my life. I've been very lucky to be supported by my family, and as best I can, I've tried to maintain a strong work-life balance. I was a little skeptical of terms such as well-being and mindfulness, but actually when I think about it, many of the activities I get enjoyment from actually epitomize the very ideals that I perhaps poo-pooed. It's very hard to concentrate on anything else when you're making your way up an ice field. It's a great way of losing the mental clutter that fulfills our minds at most times. But back to work, and this is where Paul was very instrumental. I'm was involved as a result of some of Paul's suggestions in the inflammation and repair domain. And it was when I was working alongside colleagues that the MAHSC designation, which first came to Manchester in 2009, was up for redesignation. And I'm pleased that the contribution I made to that application was successful in some small way. And again, that was repeated in its final redesignation in 2020. But medicine is a massive privilege, and it gives us lots of skills that are transferable into different arenas. And I've been very lucky to work with a number of teams in very different world than I operate day to day. I've been able to travel as a result of that. But what I've been able to do, I think, is benefit from those teams I've worked with. Teams that are very different from medical teams. And certainly I've benefited from some of the leadership methodology I've seen carry out in different arenas, as well as benefiting from pulling innovation from very different places, as well as perhaps indicated by the blue car at the top, putting into practice some of my skills, but in very odd situations indeed, problem solving outside of the norm. And this perhaps was extremely useful in how I was involved in the second novel virus in my career that bookended HIV at the beginning and COVID towards the end. Emergency medicine is very much the front line of new emerging problems, and it was during the COVID pandemic that colleagues and I felt that there were some of the presentations, some of the challenges that COVID was giving us that were worth documenting and sharing wider. In essence, some of the messaging in relation to stay at home perhaps was impacting those patients who were least able to manage at home, the elderly, the infirm, the carers. We're also very taken by the involvement of nosocomial spread, particularly in the earlier phases of the disease. And finally, one of the other aspects that we commented on was the novel presentation, rather driving a coach and horses through our normal clinical assessment techniques. It was fascinating to see how this evolved in the second and third waves, where again we still actually saw the impact of nosocomial spread as being particularly significant. Last couple of slides. We've been very lucky in the Northwest to benefit from a strong history in trauma care research. The MAHSC Centre ran here from 1972 to 2002, and we can see the legacy of that department in many of the institutions around the city. Tarn, the HCRI, again, I highlighted Tony Redmond's involvement, the Centre for Tissue Injury Repair, and the intestinal failure unit. But one of the things that I've been lucky enough to spend some time with Dan and Paul again is perhaps the next step. And we've been fortunate to receive the backing of colleagues here in Salford, and Phil Caller in particular, in setting up Connect, which the Centre for Emergency Care and Trauma Sciences. I mentioned I'm the accidental academic. The area I suspect I will be spending more time is in the teaching and training aspect, and perhaps some of the international fellowship development. You can see the rise in population health challenges within the NHS, and I suspect that prevention be it in road traffic accidents or reduction in the harm violence, delivers within the society, particularly the younger members of society, may well be areas that we need to reflect and concentrate on. And finally, again, returning back to the period of time I spent in New Zealand, the role that allied health professions and advanced practitioners can play in delivering research and academic study is one that I would hope to be pushing forward with in this new development. So thank you for listening. I hope I haven't taken too much of my 25 minutes, and I shall leave you with and hand over to Dan at that particular point in time. Thank you.
Thank you, Martin. We've probably got a few minutes, Dan, if that's okay, for any questions. I don't know, Yasmin, if there are any questions in the chat line. I can't see any at the moment. Please raise your hand.
In the chat box, but from the audience, please feel free if you have any questions. So please raise your hand.
I'll start off, Martin, just briefly, and while people are thinking of a question to ask. One of the things that I've noticed over the years in emergency care particularly is about planning and leadership in planning. And, the best made plans often don't work very well. And we're probably hearing about that in the COVID inquiry at the moment down in London. But I have to say that your work planning for the unthinkable terrorist activity in Greater Manchester was exemplary. And, the results of that have probably not had the light of day that they should. But I know that it's been very impactful both in the Department of Health and the Department and Ministry of Defence and the work that you've done. My question to you is, what have you learnt from that planning and how those plans were enacted before they were fully thought through, that is sort of going to close the loop on future planning, and something generalizable on how, as leaders, we make plans?
Okay. I think the first aspect that was foremost in our minds was the challenge of communication, and in almost in every major incident, poor communication is flagged as a persistent finding. And what we were attempting to do was remove the need for a significant amount of communication, in some respects make actions automatic. That proved to be a very difficult concept to get consensus on. I think that there was a strong feeling of people wanting to remain involved in the decision making, and therefore feeling that they wanted to feed into the decision-making process, particularly hospitals controlling the flow of patients towards them, when actually it should probably be the pre-hospital colleagues, driving those patients, rather than mitigations being put in place by hospitals, and so that I think that was a beneficial outcome from the whole process, was the automaticity of our plan. But what I would say is, don't underestimate the complexity of getting that type of planning through. I think it took us about 9 months, and as I say, it was a hard-fought battle in some aspects to get that outcome. Thanks, Martin. Yasmin, have you got a question?
If you don't mind, I do have a very quick one. So thank you so much, Martin, for such an amazing lecture, and thank you so much for sharing your journey with us. Well, as you mentioned, you're already involved in training and teaching and supporting the junior students. So I would like to ask you, what advice or what key advice would you like to give to our early career researchers or clinical fellows for their future career who are interested in both research and clinical?
I think I probably pointed to that in some aspects through my talk. Find people who know what they're doing and stay very close to them. I think I benefited immensely from figures who were able to cascade their knowledge to me, and I think you cannot underestimate the benefit of mentoring from clinicians and colleagues from all specialties and all disciplines, actually. So yes, find experts and stick close to them.
Yeah, fabulous. Thank you so much.
Thanks, Martin. Just one final question from Professor Calra, who many of you will know is the research, among many of his roles, is the RNI clinical director at the NCA. Phil.
So thanks, Paul. Yeah, great, Martin. Just one thing, actually, we've got a lot in common, because I was appointed to Salford from Auckland ICU, from critical care in Auckland, New Zealand, probably a year or two before you, I would guess. But yeah, just in your we must catch up about that, by the way. In your talk, I didn't really hear any mention of David Yates. Maybe I missed that. I was bobbing out at the time.
I'm pleased to say you did, Phil. He was on my list of
okay,
names.
right. Yeah.
So no, you're absolutely right, because David, of course, brought over TARN from America. I think it was MTOS in those days. I think it's 85. And without David bringing that over in his role as the first professor of emergency medicine here in Salford, so many of the developments that we've seen play out in the last 20 years in terms of major trauma networks wouldn't have been possible. The tool he crafted in TARN is instrumental in monitoring and informing the reconfigurations we've seen in major trauma in the UK in the last 12 years. So no, he was there. I was lucky enough to work with him for a year as a registrar before he retired. And I must admit, I shared a really insightful journey around Germany on trains, which were, if you remember, his strong passion. So yes, he is one of the names. But there were too many influential emergency medicine consultants in Manchester at the time, I'm afraid, to give a slide to everybody. But he was on slide 15 or so. Thanks.
But the legacy lives on through Connect as well. You and Dan and Paul. So fantastic. Thank you so much.
Great. Thanks, Phil.
Okay, thanks, Martin, and great speech. Thank you very much. I'm going to move rapidly on to Professor Dan Horner now, who describes himself correctly as a clinical academic. But Dan is a very special person who has developed that with the support of the NHS and the NHR, with association with the university. And I'm really delighted to welcome Dan. We share an office together in clinical practice in the ICU at Salford. And I'm really looking forward to your talk, Dan. Over.
Thank you, Paul. I'll just go through the obligatory panic as I start to share my slides. So I'm hoping you can see that.
Yeah, that's great, Dan.
Fantastic. Okay. So, I mean, thank you to MAHSC for this wonderful opportunity to talk to you all. Thanks, Paul, for the introduction. Thank you to you all for sacrificing your lunch hour on what's quite a sunny day in Manchester in late autumn. So I'm very grateful for that. I found this talk a bit tricky, if I'm honest, because we don't really get any guidance on titles or content or duration even. We're just told to talk, and so I thought everyone likes the Beatles. I'll go for a Beatles title and a nice picture to start. But what I thought I'd talk about is really how I started off, I suppose, on a research journey and a road where I've got to, what I've learned, and what I think we should be looking at next. Why should anyone get involved in research? Well, I suppose when I was in my early training stages in emergency medicine, I, as Martin has already alluded to, was surrounded by some fantastic role models in emergency medicine. So clinical academics like Fiona Leckie, Professor McWade-Jones, Simon Carley, and others who had an academic lilt to their careers, but were very present on the shop floor at all hours of the day, 7 days a week, and were using that academic knowledge to direct really excellent patient care. And they were aspirational figures, and they made me think that academics were probably overall, in many ways, superior clinicians at times. And interestingly, the evidence over the last 10 years has borne some of this out in terms of the association of research activity with better clinical outcomes in institutions. This is a figure many of you will know from a great study in 2015, looking at over 2 million emergency admissions in the NHS. And after multivariate analysis, adjusting for access to critical care services, diagnostic radiology, staffing, and other things that you think might bias this type of association, the authors still report an association between those sites who are most research active, having lower mortality for patients. And you can drill down into some of this and think why. And you can look at cancer studies where patients are randomized to placebo, compare them to cancer patients not on trials with a similar clinical trajectory, and the ones in trials seem to have better clinical outcomes. And presumably this evidence is why the NIHR has taken on a variety of national reports, why we have a UK policy paper from the government talking about the future of UK research delivery, and everyone is very keen to embed research front and centre. And if that's the why, the next is the how, I suppose. How do you get into research? Because it does seem tricky and sometimes impenetrable, but I would argue that research activity is all around us. I think when you start your careers, and really it's just driven by being curious. So anyone can ask a question on the shop floor about why you've chosen a particular medication or a relocation technique or a particular agent for procedural sedation and anesthesia. And the first aspect of research engagement really is the nurturing of that curiosity, open discussion, and appreciative inquiry. And there shouldn't be any hierarchy here. We should be comfortable asking anyone in any kind of senior position to justify their clinical choices and educate us as to the how and why and the when. And creating that kind of culture that fosters curiosity is, I think, a big step on the research journey. And that's certainly how I took my first baby steps. Because you can then turn those clinical questions into academic outputs, and you can start on a journey of critical appraisal and discovery. Many of you will have seen best evidence topic reports. There are structured reviews looking at particular 3-part questions designed to answer clinical questions that have come up on the shop floor, and they were born and raised in Manchester about 25 years ago, down the road at Manchester Foundation Trust, who pioneered an approach to evidence-based medicine that I think was quite rare at the time in emergency care. And these are still going, which is a testament to their longevity and their benefit, both for clinicians who want to get involved in research activity and develop academic interests, and for patients, of course, because people look to this resource to answer questions that they have in different hospitals around the region. There's a few examples of outputs here from the last year. Should we be giving intranasal lidocaine for symptomatic relief of migraine? Fascinating. Can we use biomarkers for chloroquine? What does the evidence say? I think Dr. Kilgore's on the call, who's recently purchased a handheld portable fundus camera for our emergency department here at Salford, and he'll be delighted to see that there's been a best evidence topic report this year suggesting that they can be used appropriately and efficiently by emergency care clinicians to make retinopathy diagnoses. So good stuff. And you can take those kind of critical appraisal questions and move them forwards to journal reviews, to journal updates, to start to cascade that knowledge to get comfortable with critical appraisal and to continue your research journey. And you can take that forwards, I suppose, to practice reviews like the kind we've published in the BMJ fairly recently, looking to synthesize the evidence around particular clinical topics, to kind of drill down on where the gaps are in that evidence, and to provide narrative responses about what clinicians might want to do in the absence of good evidence around that particular situation. And you can also start to develop your academic writing on this topic with regard to thresholds for evidence-based medicine, and how much we need to see before we enact a change in practice, what kind of different study designs are appropriate to consider. And the latter article here in these references is something I wrote with colleagues at Central Manchester, looking at the evidence waterfall, I suppose, or the tsunami, some people have described it as, that we saw during the pandemic, and how we processed that amount of evidence coming through, how we used it to influence practice and change, and where people set their thresholds. And that article's had over 35,000 downloads. Very popular, because I think people are curious about that. You know, how much evidence do we need to see to justify change in practice? And then once you've done some bets and some questions and some critical appraisal topics, you start to think, well, maybe I could have a go at primary research myself, actually. And I suppose that's how I first stumbled into real research in my registrar training. So I took 2 years out of programme to undertake an MD at the University of Manchester, supervised by Kevin McWay-Jones. And I looked specifically at the issue of calf vein thrombosis, which was relatively undertreated in the UK at that stage. And I conducted a randomized control feasibility trial looking at offering patients either therapeutic dose anticoagulation or conservative treatment with serial sonographic follow-up for those diagnoses. And that project was successfully conducted. We included a number of patients, and the test was feasibility. And interestingly, patients had equal equipoise to us as clinicians. You know, once you kind of set out the options for them, all of them weren't sure what to do, and they were happy to participate in the trial. And what's really gratifying when you undertake a research project like that, it's not just the completion of the bespoke project itself, but you can see your research then get cited and used and taken on to inform further decisions about practice in that clinical area. And this is a screenshot of a Cochrane systematic review on this topic, which utilised my MD project alongside other smaller studies to actually show a statistically significant benefit with therapeutic dose anticoagulation. And as I said, when we conducted our project, distal DVT was relatively underdiagnosed and undertreated in an NHS setting. But a recent Getting It Right First Time report has now shown that over 70% of NHS sites are using whole leg ultrasound to identify these clots, and the vast majority are treating them before they get a chance to propagate, embolize, or cause serious clinical sequelae. So that's a change in practice and a big win. And then, of course, you finish your MD in the middle of registrar training, and you've got your annual review of competency progression documents to complete. You've got specialty exams in emergency medicine and critical care. You're just about to start a young family. You know, you've got pets to look after, and you've got your thesis to write up. And it's difficult, isn't it? Because there's lots of plates to spin in emergency care, and there's lots of plates to spin for many people who try and kind of tread the path of clinical academia. And research is often the one that falls because, you know, we have to keep our other plates spinning for career progression, and research, you know, many people consider to be something that's more of a passion than it is a career drive. But I think there are lots of options to keep that going, really, within the NHS, and there's lots of appropriate reasons to keep that spinning. Most of all, career longevity, the benefits of a portfolio career, and again, keeping research active and engaged as a clinician, because we know that kind of work will influence patient outcomes in the longer term. So I looked at different opportunities for this, including funding for my time specifically as a junior consultant. I can't resist mentioning consultant timings. Martin talked about 2003 as his first appointment as a consultant. I think that was the year that I qualified from medical school. So a little bit of a gap between us. But when I qualified as a consultant, one of the first things I did was try and identify some grants that would fund a proportion of my time that would allow me to continue to do research. So not a traditional clinical academic path, but more of a kind of hand-to-mouth approach. But I was successful in some of these when I found the right question to ask. And the question I focused on was aligned to thrombosis in my MD work, but it was more about the prevention of thrombosis in people immobilized with lower limb immobilization. And when you scratch the surface of this topic, you see some really tragic cases, very emotive cases of young people who've had a fairly innocuous minor orthopedic injury and have been managed in a plaster cast or an immobilization type device, and have not been particularly informed about the risks of immobilization, the risks of thrombosis, and have suffered a catastrophic event as a result. And when you scratch the surface of this topic, you know, you find that there's real international variation in practice, with different guidelines, different clinical risk assessment tools, and there's clearly a huge question around the way we practice here. So I wanted to take this forward. I found support through the University of Sheffield, colleagues such as Steve Goodacre, and through the Royal College of Emergency Medicine as well. And I took this forwards essentially through evidence synthesis initially, working with Steve and the team, where we looked at all of the evidence to date, pulled it together, and we actually fed some risk estimates into a decision analysis model and a cost effectiveness model, looking to see if we could just take what had already been done on the topic and provide some consensus recommendations. And of course we couldn't. The evidence base was too weak really to kind of say anything concrete and conclusive. But what the benefits are of creating that evidence synthesis is that you become a mini topic expert. You have a really deep dive into a difficult territory, and then you can start to produce practice reviews. You can start to talk at different conferences, and you start to generate a buzz that aligns specialties who've had very different feelings about a topic like this in the past, such that we've been invited to publish in haematology and orthopedic journals on this topic. And we continue to collaborate with those colleagues moving forwards, because everybody wants the right result for these patients. And we all know that we need evidence to inform how we get that result. And then once I'd done some work on thrombosis on these particular topics, and I generated a clinical interest and started to develop a bit of topic expertise, I wanted to pay some of that back into clinical NHS practice. And this is the real benefit of being a clinical academic, I suppose, is that I'm still on the shop floor looking at these patients, making tricky decisions, thinking about guidelines and how I would use them in practice. So I took on a position to chair the thrombosis committee at Salford, and working with haematology, respiratory, orthopedic, pharmacological colleagues. We've gone from strength to strength, building a kind of internet-based resource for our VTE service at Salford. We have, I think, over 15 guidelines on different topics aligned to thrombosis and bleeding now, which are regularly accessed and by all grades of doctor and allied health professional working at the Trust, and have thousands of downloads every year, which is great to see, and that can be really point of care at the patient bedside. We've put that evidence forward and have been recognised as a national exemplar centre for the way we handle thrombosis and bleeding management. And as a result of that, I thought it was appropriate to put myself forwards when NICE decided it was going to write new guidelines on VTE, and working with that committee has been really insightful and interesting, and allows me to pay back some of the experience I've developed through academic work into practice-changing clinical guidance. And of course, that credibility and that experience then allows me to put myself forwards for more research applications and for more grants and for more time to ring-fence academic activity. And this is a snapshot from my NAHR Realms active project portfolio, which I think tells a really nice tale of small supported grants, working with colleagues, through to collaborating with colleagues in Scotland on different topics aligned to acute care, and then collaborating with colleagues in Cambridge, looking at more thrombosis projects, and finally running my own large-scale randomized controlled trial, which is about to start recruiting this month. So if that's, I suppose, how I got into things and how I developed my academic portfolio, I'd like to spend the next half of my talk, I suppose, thinking about next steps and how we continue to progress emergency care research. And a couple of things have become clear to me already during my first decade as a consultant. One of which is that we need to work really hard to embed research front and centre in clinical care. And we need to build capacity in emergency care, because we're a relatively underrepresented specialty when it comes to grant applications and a body of academics within the country. The second is that we need to think about strategies to accelerate knowledge translation, because that's how we get clinical buy-in, really. When people can see that research changes practice and it influences the way they care for their patients in a positive way, then, what's not to like about that? Everybody engages more in research, and we get to offer more opportunity to our colleagues and our patients. And the third is about mentorship, really, and succession planning. And I've been lucky in Manchester that I've had some fantastic role models and aspiring academic figures, as we've already mentioned. But it is challenging to find these kind of communities of academic practice in emergency care, and I think that's something we really need to work on. How have we done that? How are we doing that? How can we go further? Well, embedding research in emergency care, is something that we can all do, again, on the shop floor, by talking about questions, by delivering NHR portfolio research, by promoting academic activity, and by trying to make sure that we're all engaging in some way in research as good clinicians. But we can also kind of front load academic activity into delivery of care through associate principal investigator roles and PI roles for our consultant colleagues and staff. And we can also even translate research opportunity into guidelines. So one example here for an acute trial in traumatic brain injury, looking at hyperosmolar therapy and whether we should use one agent or another. We've actually built this into our Trust traumatic brain injury guideline now. So when the trainees and allied health professionals are managing these patients in the early hours of the morning, they come across this trial, they randomize patients, and they give people research opportunity at all hours of the day. And because of this strategy, we're the top recruiting centre for this trial in the country, which is great to see. You can take that further, I suppose, and you can offer wider engagement across sites that haven't got much experience with academic activity, and you can build capacity in that direction. And I've been lucky enough to be supported by the Royal College of Emergency Medicine to lead and develop and initiate a trainee emergency research network. We started this in about 2017, and we've had great success in this because it allows you to take away the ivory tower, to take away the 3 years of individual grantsmanship and write-up of a project that most clinical trainees feel they just haven't got time for. And it allows you to create a project with real clinical buy-in that can be then delivered by hundreds of sites up and down the country on a fairly time-limited basis. And Turn has contributed about 3 funded projects now, I think, all of which have recruited to the NHR Trauma and Emergency Care portfolio. And the total tally, I think, of participants stands at well over 10,000 patients. So a huge contribution to the national research portfolio, over 300 new investigators, GCP trained, over 100 principal investigators in emergency medicine now that have got some experience of leading a study at their site. On our last project, subarachnoid hemorrhage in the emergency department, was published 2 weeks ago. It's really gratifying to see that in print, and we managed to get Turn as a collaborative group authorship. So real recognition for the trainees who contributed to that, and I would thank those of them on the call that I'm sure did hard work. As well as a national project like that, Martin, Paul, Fiona and I have really tried hard to embed this research front and care at the NCA over the last 5 years, create opportunity for our colleagues, create opportunity for our trainees and our allied health professional workers and anyone involved in the emergency care system who has a research interest. And these are some stats that we're really proud of. I think in the last couple of years, huge numbers of trained principal investigators that have delivered studies that have been published in the New England Journal of Medicine, in JAMA, in the BMJ and others. And they're great outputs for my colleagues. They're leapfrogging me in terms of research impact, but that's actually gratifying to see because this is an absolute community spirit. It's a team sport. We all want to promote research engagement, and that's how we build capacity and opportunity and experience. How do we accelerate knowledge translation? In the last couple of minutes of my talk, well, that's always been quite tricky, and there's some tremendous stats, aren't there, about how it takes 7 to 10 years to get research findings into practice. And I think if we want to build interest in research engagement in our communities, then we have to accelerate that and make it easier for people to really realize the benefits of research engagement. Some of that, again, is about curiosity, and it's about talking to people on the shop floor. Did you see that study on this topic? Have you read that paper? Did you see that blog? Have you listened to that podcast? And online open access medical education has allowed a step change here. The St. Emmeline's group, led by Simon Carley again at MFT, have pioneered a Northwest approach to this by just disseminating knowledge translation really rapidly and with an excellent focus on what's key and what's necessary to take away from research projects for emergency physicians. And this is a nice example of our shared subarachnoid hemorrhage study again, published 2 weeks ago, an open access critical appraisal blog launched a couple of days ago, a podcast accompanying, if people want to listen to that on the journey into work. All of these things help you realize knowledge translation and help you change practice. There's also quality standards, quality improvement, national guidelines, lots of ways in which we can impact care that we deliver in emergency medicine and critical care. And these are some examples that we've done from our airway service evaluation work and our improvements in acute airway management at the Trust. So looking at I suppose, regular registry collection data, looking for continuous improvement of care, looking at iterative change in the way that we they use drug labels and pharmacology and rapid sequence induction, thinking about choice architecture and how we can make clinicians' lives easier by creating pre-filled syringes of the most appropriate induction agents so that they're easily reachable, bespoke rapid sequence induction boxes that you can pick up and take to the patient's bedside, routine and universal access to video laryngoscopy and evidence-based tools that make your life easier in a difficult and challenging situation, and then embedding all of that with multidisciplinary high fidelity in situ simulation led by some of the great educationalists we've got at the trust. And all of that package of care again will accelerate those aspects of knowledge translation that we get from research, help embed them in care, help people realize the benefits of research and help create opportunity. I'm sure Martin can remember when you would take 3 vials out of the fridge, dust them off, crack them open, write your own handwritten labels when you're about to undertake a rapid sequence induction. And I hope we've moved a lot further away from that now because of research activity. And then the last bit about building capacity and mentorship opportunities. Martin's already shown this slide, but I don't think I can apologize for putting it up again, because for me, a lot of this is about trying to build a community, really, trying to build a bit of sustainability in how we deliver research and trying to build a bit of resilience, because we are an undeveloped specialty in acute care research. We do need more people to come together. We do need many minds to make light work, and we do need people to mentor, encourage, support, and develop people who've got that academic interest, who start that initial spark. And I'm hoping that Connect can build that and add a bit of weight to it. And I'm very grateful for the support, as Martin mentioned, that we've already received from Phil and others at the Northern Care Alliance, from support, advice and guidance from colleagues around the region, and for real kind of boots on the ground, hard work from our acute research delivery teams and other colleagues in the Trust. And finally, what's all this got to do with MAHSC and the University of Manchester? Well, I suppose I'd like to offer my thanks to MAHSC and the University of Manchester for supporting my MD, for keeping me engaged in research, for offering opportunities for small grant applications, which I've worked on with clinician scientists and academics within MAHSC that have helped me develop trauma biomarker studies and other projects aligned to acute care. And I think they've had a huge impact on my career and a huge impact on building my collaborations within the region, which is fantastic. And also offered thanks to the Royal College of Emergency Medicine, who supported a lot of the work with Turn. A lot of thanks to the NHR, of course, who've supported a lot of the randomised controlled trial work I'm doing, and have invested in me personally with a researcher award recently, which was fantastic and given me a bit of breathing space. And then final thanks, I suppose, to all of my colleagues around the region. So I think I've already mentioned lots of people, but just to highlight the initial inspirational figures again, in Manchester, the national and international collaborators such as Beverly Hunt, Xavier Griffin, Steve Goodacre again at Sheffield, and others that have really worked to support me as a fledgling non-specialist academic. And then I wouldn't be anywhere near down this road without the support of my clinical colleagues, both in critical care and emergency medicine, and of course those in major trauma as well. So thanks to you all, too many to name. I hope I can continue to connect forwards and realise your investment and do you all proud. Thank you all very much for your time again, and apologies for making you miss the sunshine. Very happy to take any questions.
Thank you so much, Dan. It was a fantastic talk. So I can see a few hands coming up, some clapping, which is great, virtual clapping. Peter.
Hello, can you hear me okay?
Fine.
Perfect, lovely. I'm a consultant colleague of both Martin and Dan's at the NCA now in the emergency department. And I said it to Martin on a private message and just said it now. Congratulations to you guys for such incredible work. And you said thank you to loads of different inspirational figures across the Northwest, but you're now there and we're hanging on to your coattails as a young consultant colleague coming through. So thank you very much. I had a specific question for Dan, given my interest is in education. You mentioned quite a lot about some of the works that Emlyn's have done and what others have done for knowledge translation. Do you have any specific plans for knowledge translation using Connect? And what's your vision for it? A lot of those things are maybe other trusts and other people's projects. Do you have any particular visions for it?
Yeah, a great question. I mean, when we set up Connect, we wanted to identify some pillars that we thought would overlap and help us deliver a wraparound benefit, I suppose, because research activity is not just about the research, it's about how you engage the community to deliver that research when you think it should change practice. And education is one of our pillars. So we are trying hard to work with educators in the system already, such as yourself and Bryn Summers, the education lead for major trauma, people in critical care. I think the projects there, Pete, are really around a reliable resource that will help translate. So the Connect web pages will support that, I think, so that we can highlight research opportunities, we can highlight new findings and feed those directly to clinicians on the shop floor. I'm very keen to get multidisciplinary simulation, continuing across critical care, emergency medicine, and major trauma.
This is really stupid thing for me to try and do.
Claire,
right,
I think
you starting it.
Just put your speaker on.
Thanks, Claire.
And then the last thing, Pete, I suppose, is to think about delivering educational nuggets and prescriptions, isn't it? About how we capture that work in a cycle that will feed back and will embed. There's always been a challenge in education. I look to educationalists like yourself to tell me how to do that, really. But part of our pillar is to work with you to deliver it.
That's a great question, and thanks for the answer, Dan. Lots to learn from that. I have a quick question, which is, a little bit on my table at the minute. So the General Medical Council, for the very first time in their history, have set standards for all medical practitioners for offering and conducting research in healthcare. So this is now a national standard that colleagues will be appraised against. I think this will be very influential in other professions, the General Nursing Council, the General Dental Council. What are your views on how that aspiration can be facilitated in the NHS? Particularly, what do we say to chief executive officers in terms of the value proposition of that and the importance of meeting that requirement for the GMC?
Yeah, a great question. I mean, I think it's a very positive step, I would say first, because, alluding to the slides at the start of my presentation, I think we should be embedding research front and center in clinical care. I think everyone can engage. And I think it is part of being a good clinical practitioner. But I appreciate the challenges, particularly in emergency care, of geographical variation and workload and setting. And some of the things we've done locally to try and incentivize colleagues are, building this community of research opportunity whereby people aren't making that journey on their own. They are coming to us and saying, I'd like to get involved in research. What can I do? And then you have a plethora of options, don't you, from helping to recruit patients to a study, to answering a clinical question, to supporting a trainee, to taking on a principal investigator role. And I think curating something that offers that variety of opportunities is probably where we need to go with this. And I think that needs to be supported at every trust. We've pushed hard for research leadership PAs funded by local departments here to recognise that this area needs leadership, and it should be equally respected as a governance role, as an educational role, as an international medical graduate lead role. Every department should have a research lead, and those research leads should curate opportunity. But I think that is about curation of opportunity. I don't think it's about telling people what to do. I think it's about saying, here's our hub. We have a variety of ways in which you can demonstrate to the GMC that you are an active engager with research. You tell us what you want to do, and we will support you as best we can.
Thanks, Dan. That's a lovely answer. I realise that we're a bit pressed for time. We probably just take another question before summing up. I don't know if there's any burning questions, but otherwise, thank you both so much. Congratulations on the promotion. We're very proud of you at the university, and I'm personally very proud of both of you, having spent nearly a lifetime with you working so clinically and academically. So thank you so much, and we look forward to the opportunities for receiving more applications to the MAHSC scheme in the next diet. Thank you.
Thank you so much, Paul. So this is the end of our event today, and I would like to thank all of you for joining us today and spending your lunchtime with us. So thank you so much, and I would like to say huge congratulations to both of you, Professor Horner and Professor Smith, so for your incredible achievement, and hope to see you all again for our next MAHSC Inaugural lecture, which is planned for the end of October. So please keep an eye on your inbox and you will hear more about it hopefully soon. Thank you so much. Enjoy the weekend, everyone. Bye.
Thank you.